We always say that people are our greatest asset, but I'm not sure the NHS acts as though they really believe that people are their greatest asset. We have more skill mix than anywhere else in Europe. Interesting fact, we've no idea if that means that we're more productive or less productive. Yeah, you're going to have to build up community services. You can do it with new money, and that's clearly not on the table. However you look at it, the productivity from particularly acute care has gone down, and the number of staff in situ has gone up. I wouldn't be doing my job. If I was popular all the time, I never want to go to another workshop about a vision for neighbourhood healthcare. What you can see in all of them, though, is even after 10 years, you don't have a perfect system. Parity of esteem doesn't exist anyway, we've already just talked about. So, it's much, much more highly esteemed to work in a hospital. Yes, I hate the phrase discretionary effort.
Voices of Care, the healthcare podcast.
Thea, welcome to Voices of Care, and thanks for walking over, and we're delighted to have you.
Yeah, I'm delighted to be here. Thank you.
I suppose it's an obvious statement, but the NHS is facing quite a significant transformation, huge pressures, busy time for Nuffield Trust and the work that you're doing, obviously.
Yes, I mean, there's always work to do, and it's a interesting time to be in a think tank and trying to do what our charitable purpose says, which is to provide evidence and thinking for better healthcare.
And not be afraid to challenge orthodoxies either.
I wouldn't be doing my job. If I was popular all the time by everybody in every political party or in NHS England or DHSC, I wouldn't be doing my job. My job is to bring the right evidence, the right thinking, to bring it together and to present that in the best way possible. We are an independent think tank as well. We're not politically aligned.
Yeah.
It's important for us that whoever is leading the country at the time, who's ever leading NHSE, DHSC, that we can help by providing that thinking and that capacity. We don't have to challenge. If it's all evidence-based, we'll just go crack on.
Okay, well, on that point, let's talk about one of the shifts. We're not going to go through all the three shifts. The shift away from hospital to community. It's not a new narrative. It's been around, I think, Hospital Plan of 1962 talked about the move to community. 1974, I think the 5-year forward view. So there's so many policy initiatives. Yeah. But I wanted to get your view, firstly, around terminology. You've got such a long experience within the NHS itself. Unpack, what does that mean? Neighbourhood health teams, multidisciplinary teams. There's lots of phrases going around, and I just wanted to get underneath all of that. But what does that actually mean on the ground?
Well, we could be here a long time, couldn't we?
Succinctly.
Possibly. The issue is, indeed, what does it mean to say hospital to home? It could mean we're going to take hospital services and we're going to do hospital services in people's homes.
So virtual wards come to mind a little bit longer?
Could be that we're going to say what we really need is more capacity and more people working in this community space. We're not moving, we're just building capacity. It could mean that we're going to do services that are traditionally in the hospital, in the home. There's a whole range of things it could mean. Yep. And you've also got to be clear, what problem are you trying to solve? What are you doing this for? Are you doing this because you're going to save money? Are you doing it because you believe you're going to provide better care? Are you doing it because hospital at home is a place where you feel you're going to be able to do more that's about preventative health, more about holistic health? It can be all of those things. But I don't think it's necessarily completely clear yet what part of the problems that the NHS and society face we're aiming to solve by this and what the outcomes are we're wanting to see.
Absolutely. Now that's important, and I wanted just to pick up on one of those things, because one of the policy aims is, I think, certainly by the present government made quite clear, is that there is hope that this will reduce cost. Mm-hmm. It will actually shift a cost from hospital to community setting, and the overall budget of healthcare spending will fall. I think that is the claim that's being made. Now, going back to evidence-based, what does the evidence tell us about whether that's actually likely to happen?
We can't find that does happen. But what can happen and should happen is that by having really excellent community services and primary care services, you create more capacity for a hospital to work in a much more productive way, for a hospital to do what hospitals should be doing. Any hospital chief exec, any hospital leader will tell you how much of their work is warehousing people, or how much of their work is taking on people who shouldn't be there, who should be somewhere else, knowing that they're picking up the effects of poverty, knowing that they're doing a whole range of things. What the research tends to tell us is that where you have really excellent community services, primary care services, preventative services, what you allow your hospital to do is to be a hospital and to get on and to be more productive, to use that capacity in the right way. Remember, we've got hospital services that are on the whole 97% occupancy, 98% occupancy. There's not a lot of flex. So if you have really good community services that's taking, say you get occupancy down to 85%.
What might that mean?
That would be a tremendous opportunity for the hospital to work in a better, different way. I'd question whether or not it means you can take that money out, whether or not you will work in a more productive way. Second point, of course, is that medicine, healthcare, tech is always changing. We're always developing new ways of treating people, new ways of intervening. So at the same time as you're building up community capacity, no doubt something else will come along about what you can do and how you can do it. So the idea of a simple seesaw financially, I think is going to be quite difficult to realise.
And I think the interesting point there for me is that some of the mechanics of that, there's also quite a lot of complexity, because the funding flow will need to change. And you'll know that the evidence since 2016-17, last few years, 4.4% increase in the budget going to hospitals, a fraction of that going to community. So that's going to be, is that going to be a bun fight? Because that will have to change, will it not?
Well, yeah, you're going to have to build up community services. You can do it with new money, and that's clearly not on the table. You can do it by moving people.
Yeah.
There's a lot of people doing rehabilitation services in the hospital. You could look at moving a lot of those staff into being proactively a pull service, doing rehabilitation. Obviously, you've got to do some rehabilitation in the hospital, but primarily your rehabilitation being home-based. There's a range you could move your staff around. You differentially are going to have to invest. And there is some evidence from places like Denmark that if you put different types of incentive in the system, so basically you're penalised if you look after as a hospital for a patient that should have been looked after in the community, you're going to lose money. It's quite a blunt tool. But I could see that you could bring some of that commissioning powerful purchaser into play. We've not seen that particularly work in England before, but maybe.
Maybe. I'm going to come back to the international examples. I think that's really interesting. I know the Nuffield Trust has produced a really interesting article on that, looking at Ireland and Denmark. But staying with staff, we might need to reimagine the way people are working, multidisciplinary teams. That's also going to require changes in contracts, and these things seem arcane and very dull, but they can be quite hotly contested, can't they?
Oh, the devil is always in this detail. I think, I never want to go to another workshop about a vision for neighbourhood healthcare, okay? I'm just putting that out there. I've been to enough. I know what the vision is. I don't think any of us don't know what the vision is. We can argue about a whole range of stuff, which is what it comes down to, which is about who's leading it, who's in, who's out. But making it work, and I did have a job where for 9 years I worked to try and make neighbourhoods work.
Yeah.
It's always about people, power, politics, but it's also about detail. If I'm going to have my community matron, my physiotherapist, my OTs, etc., working in a team and run by the GP, say we all agree I'm going to have them run by and employed by.
And that might happen according to what we're seeing.
They're different terms and conditions.
Yes.
You lose your continuity of service now being run in a GP practice than you do in a hospital. This is not easy stuff. The salary scales are different. The pension arrangements are different. Your base is different. Your right to training and development is different in different parts. These are not easy things to overcome. Parity of esteem doesn't exist anyway. We've already just talked about. So, it's much, much more highly esteemed to work in a hospital. Whether you're a clinician or you're a leader, that's where you're seen to be successful and to be powerful. You've got a whole range of issues you've got to work through to sew all of this together. And if you don't spend time on the detail, you trip yourself up.
Now, that's a pretty stark and candid thing to say, as I've expected from you. Let's see if we can draw out some of the international comparisons, maybe with some lessons, and from your own experience. Looking at what Nuffield Trust have written on this, I think they drew on Denmark, which is about to go through a big transformation like this, Ireland, that's coming out the other side. And one of the interesting things I found from that commentary of yours was that actually to make that switch successful, it didn't mean that there was less spending on hospital prior to the transformation. No. That's what made the work in Ireland more successul.
Yeah, I mean, we brought out a blog. We will have some substantial research coming out, which may be out by the time this goes out, which will look clearly at Denmark and as you say, Ireland. And there are some big differences. One, as you say, is the investment in hospitals and making sure upfront, particularly in Denmark. Yep. Denmark is always in the top of the league for some of the best hospitals in the world. They invested heavily in hospitals. They did close some of their rural hospitals.
Right.
However, they didn't really close them. They transformed them into community hubs. So you weren't taking away, you were putting rehabilitation, children's services into that place. Both Ireland and Denmark have invested heavily in community services. This was not something that was predicated on a shift of money. They've all found it really difficult. There isn't an example where I can go, and if we just did what Denmark did, it would all be fine. We just did what Ireland did, it would all be fine. They've got community hubs. Some of them have been great, which is similar to those neighbourhood centres. Some of them haven't been great at all. Some are working well. What you can see in all of them, though, is even after 10 years, you don't have a perfect system. You haven't got a contained healthcare budget. Healthcare spending, I'm sure you're more than aware, is growing globally. It's not going to not grow.
So I think the reality, if we talk about the brass tacks, that's going to require some honesty in communication, expectations about timelines. We've talked about 10 years and they haven't quite made the shift. We've talked about the staff, and I think in the blog that you talked about, there was, I think Ireland was saying there was a battleground with the staff and trying to change contracts.
Yeah, they had a battleground with GPs in particular because they were changing contracts.
But the fascinating thing I found from that piece of work was actually the third element was there was clarity about the how. And that helps. I think you're on record as saying, for this to work, you need to have a boring, relentless focus on this particular change. I think you quoted in your summit, I think it was Peter Hyman, you've got to, it's the grind, not the grand
Yeah,
things.
that's right. I like that quote.
It's a beautiful quote.
Yeah.
And it's actually going to be the day-to-day mundanity of getting these things over the line and communicate them.
Yeah, that's why I say I never want to go to another workshop, which is about a vision, because visions are easy. Implementing visions is really hard. And there's been a lot of critique of the 10-year plan about the fact that it's a compelling vision, but where's the implementation? And implementation is hard work. And I understand that's coming, but it's not even hard work for a year. It's not hard work for a month. It's hard work for a very significant period of time. And it's a relentless focus on getting those things over the line, and that everything you do aligns to that. You make it really clear. If the shift is hospitals are home, to use the jargon, if we all decide we know what that means, that's really what you're doing, and you're going for it in everything that you say and do. And that's hard.
Right. So this takes me on to, I think, a topic which is very close to your heart, back to your clinical psychologist expertise, because all of this is about change and the psychology of change. And you've spoken very, very powerfully. And I'm going to use a word which is thrown around a lot, not easy to define. And that actually, this is about culture. The NHS looks like a machine, I think you said. But actually, to you, it's a culture, it's a group of people. Talk to us about how important communication and having a mutuality of understanding language and terms are to make that change possible.
Well, I mean, inevitably, I believe it's all about people. The NHS is all about how you lead people. We always say that people are our greatest asset, but I'm not sure the NHS acts as though they really believe that people are their greatest asset. And change is all about how you bring people with you and how you understand where people are and how you understand why things aren't working or why things are blocking, and that you go in there with real openness and curiosity, not with an idea in your head about understanding it. I talk about an ethnographic approach to change and an ethnographic approach to understanding, by which I mean you go and you walk the floors, you go and you listen, you're alongside people, you don't make an assumption about what you believe is going on.
Right, because what's interesting, that there's been a four-letter word that's literally I've seen dominating this discussion, and that's data. And data is really, really important. But you've added that actually data alone is very, very arid. And that ethnographic approach requires, I think you were quoting Gilbert Ryle or Clifford Geertz, a thick description.
Yeah, I was going to say thick description, which is a bit of a clumsy phrase. But thick description is a really well understood term in sociology, and a well understood term actually by big business, which is that your data isn't just the numbers on a piece of paper that shows that Amy does 6 things in an hour and Bert does 12 things in an hour. If we really want to understand, we've got to bring that numerical data together with the ethnographic data. And when you've got that, you've got thick data, you've got thick description, you've got a real understanding about what's going on. And with that really deep understanding, you have the ability to create change and to lead change. Without it, you will get things wrong. And you'll stop being curious.
Yeah.
And being curious is really fun and it's really good and it gives you interesting answers.
Is that ubiquitous across the NHS system, policymakers and providers?
It's not ubiquitous across people.
And that's because of the
NHS are people. So there's some people who are really comfortable in what I'd call liminal spaces between things. Spaces where you don't know if it's black, it's white, it's grey, it's complicated. And there are some people who are really comfortable in those spaces, and there's some people who aren't comfortable in those spaces, and it's just a human characteristic.
Right.
But actually, I believe the ability to lead and to lead complex change in the NHS and to lead it now is the ability to thrive and to be comfortable in an area where you don't know all the answers.
Draw that out a little bit for us, because people often make the assumption that it's a complicated system, but actually it's a complex system.
Yeah, somebody once explained to me the difference between complicated and complex. And I sometimes use the example if I'm talking on a stage by saying that if I throw a ball to you, we could pretty much predict by physics, probably not my throwing skills, which are very, very poor.
Or my catching skills.
Yeah, but we could predict by physics and my height and your height how that ball's going to land. It's complicated, but there is something that will predict that.
Yeah.
However, if I'm holding a bird in my hand and I say I'm going to get this bird to fly to you, unless I've trained it, we actually don't know where the bird's going to go. We've got quite a lot of predictions that ornithologists could give us, but it's not linear. The bird could go and sit on the floor. The bird could go and roost in the ceiling. And that's a complex system. There's lots more bits of information we need than the physics to tell us about the bird. And the NHS is complex, which is what makes it wonderful and endlessly great to work around. But it means that change in such a multifaceted system is not the technocratic factory line change that is sometimes imagined.
And it also, I suspect, the corollary of that is that there has to be this human element, this thick description, space for psychological safety. Otherwise, there's going to be blame. We've had league tables that have now been introduced as an old idea in a new guise.
Yeah.
That can bring unintended consequences, which I think behavioral economics tells us that we need to look for.
Always. Yes. I mean, we could go down a rabbit hole talking about the league tables, but more broadly, you don't get the best out of people. None of us get the best out of people unless we are working in an area, in a place where we feel psychologically safe. And
Yep.
Amy Edmondson has written a great deal, so people know her writing very well. And many other people as well have talked about that. And broadly, I think of it in terms of if I'm the senior person and I come and ask you what's going on, and we don't have a very good relationship, and you're a bit scared of me, and I say, "Have you done that piece of work?" And you say, and you panic because you haven't done it, and so you make something up,
Right.
and we, and to get through. But actually you haven't done it because you don't understand. I've not been clear. You haven't got the right resources. You're panicking. Psychological safety would mean that you feel comfortable to tell me all that. You feel comfortable to say to me, look,
I didn't do it because.
I didn't do it because of this. I didn't because of that. And we can really have a conversation that means that maybe we can solve the problem. And we can really understand what's going on. And it's more likely that actually the work will get done rather than us pretending.
And I think that's a big lesson. I mean, if we won't go through all the history, but obviously Francis, Mid-Staffordshire, was about a blame culture where people didn't speak up. Ockenden, there's not so many of them. Just very briefly, before there's a big topic I want to come on to, but just very briefly, that sounds convincing, and I think the evidence is very clear from what you shared. Are we seeing evidence of that? You've been working in the enabling workforce stream for the 10-year plan, and what are the perhaps 2 or 3 things where we can actually enable that type of psychological safety to be embedded systemically? I mean, it's a very big ask, but just wanted to see what you're seeing on the ground.
I think all leaders, whether you're a clinical leader of a team, you're the chief exec of an organization, you have the ability to provide psychological safety in your own organization. I sometimes think it's like you're holding an umbrella up to protect your organization. So there are a wide range of chief execs, directors of finance, medical directors, nursing directors who show extraordinary psychological safety. I don't think the whole system is psychologically safe, which is why I often picture them with an umbrella, holding them up, because I think you've got to have the whole system. The whole system would mean the Treasury, DHSC, NHSE, regions, ICBs. People are very worried at the moment. When you're worried, you're not at your most psychologically safe. So there's a lot of fear and a lot of anxiety in particularly those levels. And that makes it a more fluid situation for everybody to work in. But for it to really thrive, you want everybody to feel that level of safety.
So that's a work in progress. Perhaps the new workforce plan might have a golden thread of psychological safety. Who knows?
Who knows? Who knows? Maybe, who knows? I don't.
I don't know. I'm.
So neither of us know.
But I'm hoping. So we'll have to live with that uncertainty.
We will.
Okay. I wanted to devote the last part of the conversation to, I don't think it's an exact analogy, but Gilbert Ryle, you'll know, of course, talked about a ghost in the machine. And if there's a ghost or a nirvana that everyone seems to be talking about, it's the elixir of productivity. We need to increase productivity in the NHS. Jeremy Hunt mentioned that in his spring budget of 24. It's in the Darzi report. It's in Mr. Streeting's requirements in the operational planning. How important is that? What do we mean by that? Because it can become a very arid subject, input, output. Firstly, the 10-year health plan says we need to solve the productivity crisis. Is there one?
Yes, there is one. We have more staff in the NHS, and in the way in which we calculate productivity, which is primarily a metric that works well for acute care and hospitals, which goes right back to the beginning about why, but let's even in that, it tries to be, and it is more sophisticated than many measures from across the globe. It does take some aspects of outcomes, so it looks at readmission rates, etc. However you look at it, the productivity from particularly acute care has gone down and the number of staff in situ has gone up.
Yes, and that's, I think the numbers that I've seen, January to July 24, 18% increase in consultants, 23% increase in nursing, but actually elective admissions nowhere near that number. I wanted to tarry a little bit on how important this is, because it's not just a dry academic subject. If we secure some of the projections, if we secure a 1% increase in productivity or a 2%, the difference in the budget in a few years is 20 billion.
Yeah.
So it's a really big subject. But going back to your psychological safety point, it seems to be fraught. You've called for a productivity truce between the parties.
I did.
Why do we need that?
Because I think it's all got very stuck. Not everywhere. There's some great work going on, actually at all levels. But as a debate, it's become slightly arid and slightly stuck in terms of blame and blame culture.
So we've all agreed that, broadly speaking, there's a consensus that it has deteriorated.
Yeah.
But that's the only consensus, probably.
I think there's looking at data and trying to understand what's going on. Is it complexity? What it feels like is, not feels like, what has happened is at a point in time, a level of, going back to what I talk about curiosity, level of curiosity about the situation dried up, really.
Well, people are fearful, aren't they? There's a lot of defensiveness, what I see in the debate around productivity.
Yeah, I get that. And if you suddenly say to me, Thea, you used to do 10 of those an hour and you seem to only do 4, it's pretty, I'm going to feel pretty anxious.
Yes.
Because I'm like, And actually unpicking that, well, why? Why is that happening? And, when you're doing root cause analysis for an incident, you sort of, they say it was 7 or 11 layers of why that you ask, why? But trying to look at what's really happening. So we did some work at the Nuffield 2 years ago when I first joined, which was, I was curious about the nurses and AHPs. They're the ones who run hospitals, nurses run hospitals in particular. And we looked at the nursing workforce, and from 2015 to the point we did the research, and I can't remember off the top of my head, I think it was 2021, we had some huge differences in that workforce. The number of nurses who were new in post was something that had gone up by 11%.
Yes.
The number of nurses from overseas had gone up by something like 23%. The number of nurses who were just qualified and in, et cetera. So you have all these extra staff, but the first question is asked, who are they?
Yes.
Now suddenly you find out, well, this nursing workforce that's running much of your hospital is younger. That's great. Young people are coming in. They're new in their grade, so they're new to grade 5 or grade 6 or grade 7. That's great. They've been promoted. But let's think about what a new, young, newly promoted workforce is like. If you and I are asked to go and run the cafe on the corner, possibly we won't run it as efficiently. We'd make a good go of it. It'd be fun. We'd have a nice day.
Absolutely.
But I imagine we probably wouldn't run it as efficiently and as effectively as the people who are in there because we're new in post.
Yep.
We may run it more efficiently and effectively if somebody mentors us during the day.
Yeah,
so now you've got somebody supernumerary, as you'd say in the NHS, who's actually helping and supporting us. What I'm using by the example and going on one example is you have to dig. Here are all these staff. Who are they? How experienced are they? There's a massive debate, clearly, about bringing a workforce in from overseas.
And that's tied to broader discussions.
Much broader. But let's just put on one side and say we've had that in place for many, many years. So what you do is you bring in a workforce that's highly experienced, really skilled in their own country. And you then say, we've got 20% rise in that nursing workforce in the NHS. Crack on.
What does that mean?
What does that mean?
And you're saying that actually, until we have psychological safety,
we don't unpick it.
We've got that horrid phrase, but the one that's perhaps most damaging to any policy or society, no-go areas.
Yeah, we should never have any no-go areas. I mean, it's easy said than done. But
of course.
You've got to look at. So I think it's a great cause of celebration that we've got more young people in post. We've got people who are new in their grade. But actually, that can also lead, as we've described with our experience of running the cafe, that we may not be as effective. We may not be as efficient. We've also got the biggest skill mix in Europe.
Yeah.
Really interesting. I didn't know that before I started looking at the research at the Nuffield, but we have more skill mix than anywhere else in Europe. Interesting fact, we've no idea if that means that we're more productive or less productive.
And you'd have thought somebody would have.
We don't know. There
Right.
isn't evidence, because I've asked the questions to people who are expert in my organisation. If you look at Germany, that has more doctors in it, Austria, more
Yep.
doctors. So I say, are they more efficient? Are they more effective? We can't really evaluate it. We don't really know. What we do know is we've got a massive experiment with skill mix that's going on in this country. We actually don't know a great deal about what it's doing. There's some research. Alison Leary did some work for the Queen's Nursing Institute, looking at the role of practice nurses and other R's roles on the effect of GPs. And what she found is it made GPs less efficient.
That is interesting.
And practice nurses, because what you had, apart from extended scope physios, if they stayed within extended scope physios, and community pharmacists in those roles, within a particular role, what often happened is people's scope crept, but then good people in those posts would go, I think I need a bit of supervision, or I just need to ask a question. So actually, they were intruding on the practice nurse or on the GP to ask for support and advice, quite rightly. But actually, the idea that this was going to lead to efficiency and effectiveness wasn't necessarily doing so, but only by unpicking it, and unpicking it in a way where you feel confident to do that, because you start wading into, let's look at how explosive the issues around PAs has been.
Yes.
You're going in areas, we talked about no-goes, where people are, we don't want to
we
pick
need
that
to
up.
overcome that. But
You've got to go there.
But the policy behind that is to have the psychological safety to say, actually, we're trying to understand the problem at the moment and have the evidence for it. That's interesting. I want to just touch on a couple of the other levers around productivity, because it's dominating the discussion. The other one that comes to mind, it's presented as a bit of a magic wand if you look at the 10-year plan. And I promised myself we wouldn't recite all 3 shifts, but I'm going to recite the
We're
next
going to
one.
go to it.
We're going to do one of them.
Tech.
We're going to go to tech. We're going to go to
Yeah,
tech
okay.
because it's there. I mean, it's clear. The big
Yeah,
bets.
sure.
Oh, if we do all of this, tech, AI, all of this stuff is going to bring and deliver that productivity, 2% or whatever we want to call it. What's the evidence there? There's been some good conversations around that Nuffield have published, saying, well, actually, we better get the basic infrastructure right before we talk about
I think
anything
a lot
else.
of people have said, and to be fair to the 10-year plan, it does say we need to get the basic
it's a great
infrastructure
aspiration.
right.
Yep.
Because at the moment, it's the traditional story people tell. It takes me 7 minutes to get my computer going. It takes me blah, 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 blah. I've got to use 4 screens to do the discharge for somebody, etc. So you've got to get all those basics right. You've got to get one patient record, which the aspiration is. You've got to get a proper platform that pulls data in a way, get the app to work well. I like the NHS app. I think it's great. Get those things to work well. Are you going to then be able to move to where tech transforms productivity? I think there are areas where we already can see it is, which is great. One of the things I found absolutely fascinating, we haven't published yet. We have some work that we may be publishing, but there's some work coming through from other places as well. It's this fascinating question. It would fascinate me because it's about people, which is, I give you a bit of tax out, and it means that you're more productive. You don't have as much paperwork to do. You don't have much writing up to do. And I go, that's fantastic. So will you be able to see 3 more patients a day? And you say, no, I'm going to go home on time.
Right.
Or no, I'm going to go and have lunch and have a break and meet a colleague. And the fantasy is that you're going to say, I'm going to see 3 more patients in that time. But you actually say, I'm going to see the same number of patients, but I'm not going to have a nervous breakdown.
So some of this, I'm talking about nervous breakdowns or things that lead on to them. Staying with people briefly, as we come to the conclusion of our conversation. I mean, we haven't got the time to talk about all the factors, but a factor approach, a human factor approach would be quite interesting. Staff morale, I want to touch upon that. I mean, the NHS staff surveys are very clear.
Yeah.
There's been some improvements.
Yeah, there has.
Which is to be celebrated, but there is still a significant issue. I'm just going to pick out burnout. I'm going to pick out the effects of bullying and discrimination. So all of these things are still going to be areas that we need to, as you would say, understand what the effect of that has on discretionary effort, for example.
Yes, I hate the phrase discretionary effort. Sorry,
Right.
because discretionary effort means unpaid overtime.
It does.
So let's just be really clear and call what it is what it is.
Well, it's been prevalent in the whole system for a very
Yeah,
long
so
time,
we
as
talk
you will
about
know.
discretionary effort.
Yep.
What we really mean is I've asked you to stay for an extra 2 hours and I'm not paying you for it. So we have to get to grips with what that really means. We have to understand that. But we also know, somebody will stay an extra half an hour. We'll go and see Mrs. X and et cetera, et cetera. Because we've got a good culture, and you also know that I'll do it for you.
Mm.
And we're in this together. So it is really those very building block things that make this work. It's all about the people. It's not all about the people. You've got to have the tech. You've got to have an office. You've got to have a chair. You've got to have. I mean, say that. I've just been speaking to somebody who was talking about the fact there aren't enough chairs in their A&E and they can't get enough chairs. So it's literally you've got to have enough chairs.
Right, so this is a capital deepening, as Professor
It's like
Diana
chairs,
Coyle
guys,
said.
just chairs. But you have to listen to people. You have to be alongside people, and that culture will be what keeps you right.
One final point on that, because it's you talked about taking examples from business, and there's many examples from business theory that make their way into the NHS. And one of those is to break down processes and therefore find efficiencies for technology. Now this that difficult phrase,
Taskification.
McDonaldization or taskification. Talk about that, because it seems to promise efficiency, but we're going back to that law of unintended consequences.
Yeah, so it's Richard's work on McDonaldization, which is a very difficult word to say in a podcast.
I think I managed.
You did it very well. And the idea that, as we all can see, if you're getting McDonald's, there's one person doing one task, one person doing another task. It's extremely efficient. And there are processes within the NHS where you can see that basically factory line approach, it can be very helpful. However, anybody who is sat on a ward and seen the number of people coming to see their relative and nobody holding the whole story, forget even somebody in the community, but on the ward, somebody not holding the whole story about how much has she eaten, how much pain is she in, how many times has she been out of bed today, who knows and has held the story and remembers the daughter, etc. We'll see that the taskification of ward-based jobs has not led to a greater outcome of better care. As far as we can see, it's very under-researched, but there is work on taskification and workflow. And again, we're in the middle of a huge experiment in this country. We're taskifying a lot, and we're skill mixing a lot.
And people are fearful.
And we're not actually doing an awful lot of evaluation about what's happening as a result. It could be the most interesting experiment. It could lead to amazing outcomes. We do know, however, from some of the work on McDonaldization or taskification, that on the whole, people get a level of satisfaction from doing a whole task, from completing that task, more than they get from, I'm just the person who puts that piece of cheese on the bun.
I guess to finish off the very final point, to circle right back to your own clinical background, the importance of people, psychological safety. Let me give you that as a peroration. How do we make that sense? Because at the end of the day, everything I'm hearing about here from this conversation is really fascinating. All of these different levers, the machine can't be well, to use that phrase, unless we have psychological safety at every level and understand that culture is not a soft skill.
Well, I absolutely believe it's not a soft skill. I think understanding, I don't know, when I was a chief exec, understanding my performance data, understanding my finance data, putting in place assurance mechanisms, a whole range of things you have to do in a leadership job. I don't think that's stuff.
Yeah.
Running a rota well. There are a whole range of things, understanding clinical governance, researching an incident. There's a load of things you need to do. The most important thing you need to do is create the right culture for everybody to flourish in and for everybody to feel safe in. And places like Google have recognized that. It's a well-known piece of work, the Aristotle Project. You know, these are companies who have put a lot of investment into the idea of psychological safety. And it's not because they're lovely and fluffy and soft. It's because they want to make shed loads of money.
Right.
So I leave it at that.
there's a message there for the government.
It's not a message from the government. It's just a conversation with you.
It's a
but I
for all
think
stakeholders.
it's really important.
Well, I would love to invite you back to have a further conversation, because I think let's see where this demand or call to action for psychological safety, because if it is really ultimately about people, that's what's going to turn the dial.
Thank you.
Thank you for giving us your time and for your candor. Really appreciate it. Pleasure. If you've enjoyed this episode of Voices of Care, please like, follow, or subscribe wherever you receive your podcasts. And if you want to learn more about how we're turning the dial on health and social care debate, please visit newcrosshealthcare.com/Voices of Care. In the meantime, I'm Suhail Mirza. Thank you for joining us today, and I look forward to seeing you on the next episode. I think that's what they call a wrap.
Voices of Care, the healthcare podcast.